Welcome to the Natera Academy Short Take series on hereditary cancer screening. Natera Academy Short Takes are brief educational sessions to review helpful facts and information for the benefit of our healthcare providers. My name is Noelle Goedde, and I'm a certified genetic counselor and part of Natera's medical science liaison team. In this short take, we will explore Lynch syndrome, which is also referred to as hereditary non-polyposis colorectal cancer. As we have reviewed in previous short takes, the topic of hereditary cancer continues to be raised among professionals and community sectors alike. Many individuals are asking their healthcare professionals whether their personal or family history indicates an increased risk of cancer, whether medical management can effectively address these risks, and whether they should be tested for alterations in the genes responsible for hereditary cancer. Today, we will focus on the genes responsible for Lynch syndrome, the associated cancer risks, and the medical management recommendations for those individuals with Lynch syndrome. All cancer results from an accumulation of mutations in genes that normally control cell division. Most of these mutations are acquired during a person's lifetime, but in some individuals, an initial mutation in a critical gene is inherited. Approximately 10% of colorectal cancer results from such mutations passed down from either the mother or father, called germline mutations. Lynch syndrome is the most common cause of hereditary colorectal cancer. The genes affected in Lynch syndrome include MLH1, MSH2, MSH6, PMS2, and EpCAM. Other hereditary colorectal cancer genes include APC and MUT-YH. Screening cancer family history is geared towards identifying patients either at the highest level of risk who carry a germline mutation or those at familial risk with no mutation identified that still have an increased risk due to the family history of certain cancers. Approximately 5% of all endometrial cancer is hereditary. The majority of hereditary endometrial cancer results from inherited mutations in the genes associated with Lynch syndrome. Endometrial cancer is a hallmark cancer in women with Lynch syndrome. It is important to know that endometrial and colon cancer are both hallmark cancers for Lynch syndrome. Lastly, approximately 25% of ovarian cancer results from inherited genetic mutations. Today, we are discussing a portion of the 7% of all ovarian cancer that is hereditary but not due to BRCA1 or BRCA2 mutations. Lynch syndrome is associated with an increased risk of ovarian cancer and falls within the 7%. Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, is caused by mutations within 5 genes: MLH1, MSH2, MSH6, PMS2, and EpCAM. Lynch syndrome increases the risk of many types of cancer, particularly colon cancer. People with Lynch syndrome also have an increased risk of gastric and pancreatic cancer as well as others. Additionally, women with Lynch syndrome have a high risk of endometrial and ovarian cancer. The prevalence of Lynch syndrome is actually the same as hereditary breast and ovarian cancer syndrome. Approximately 1 in 300 to 1 in 500 people in the general population have a Lynch syndrome mutation, drastically increasing their risk for cancer. Mutations in these genes are inherited in an autosomal dominant fashion. This means a person with a mutation has a 50% chance to pass it on with each pregnancy. Although breast cancer is more common in women than men, the mutation can be inherited either from the mother or father. If a mutation is identified in an individual, there would be a 50% chance for their children to have the mutation, as well as a 50% chance for their siblings to have it. For individuals who have Lynch syndrome, their cancer risks are drastically increased compared to the general population. The specific percentages vary depending on which gene the patient has a mutation in. The endometrial or uterine cancer risk is up to 57%. Colorectal cancer risk is up to 52%, and the risk for ovarian cancer is as high as 38%. These individuals also have up to a 50% chance to develop a second Lynch-associated cancer in their lifetime. For example, someone who previously was diagnosed with uterine cancer is also at a high risk to develop colon cancer or ovarian cancer later in life. Now that we've reviewed the basics of Lynch syndrome, let's discuss identifying patients appropriate for genetic testing and the importance of identifying these individuals. Red flags are based on medical society guidelines and are designed to identify patients who require further evaluation to determine whether genetic testing is appropriate. While the society guidelines may vary from one to the other, features of individuals and families that are concerning for Lynch syndrome include colorectal or endometrial cancer diagnosed under the age of 50, 2 or more Lynch-associated cancers in the same individual, and lastly, 2 or more Lynch-associated cancers on the same side of the family. Lynch syndrome-associated cancers include colorectal, endometrial, ovarian, gastric, pancreatic, biliary tract, brain, and small bowel cancer, and in some cases, sebaceous adenomas or carcinomas. Individuals who carry mutation in a gene associated with Lynch syndrome have a dramatically increased risk of colorectal cancer, uterine, and ovarian cancer, as well as other types of cancer. Numerous published studies have documented the efficacy of various medical management options to reduce cancer risk in those who carry a mutation. Those options include increased screening, prophylactic surgeries, as well as risk-reducing agents. The benefits and limitations of each management option should be considered for individuals with hereditary risk. In the following slides, we will review the guidelines that are in place to manage cancer risks associated with Lynch syndrome. When a diagnosis of Lynch syndrome is made, the National Comprehensive Cancer Network, or NCCN, offers screening and surgical recommendations. First, we will focus on female patients who have a Lynch syndrome. With respect to colon cancer screening, the NCCN recommends they undergo their first colonoscopy between ages 20 to 25, or 2 to 5 years younger than the earliest diagnosis in the family, and they should do those every 1 to 2 years depending on findings. For the endometrial and ovarian cancer risks, patients can also consider annual pelvic exam, endometrial biopsy every 1 to 2 years, and annual cancer antigen 125 testing with transvaginal ultrasound. However, guidelines do discuss that screening for endometrial and ovarian cancer have not proven to be sensitive or specific at identifying early-stage cancer. Because of this, the following surgical procedures may be recommended for Lynch-positive females. To prevent the development of endometrial and ovarian cancer, the NCCN recommends consideration of a total abdominal hysterectomy and bilateral salpingo oophorectomy in the early to mid-40s or upon completion of childbearing. Male patients with Lynch syndrome should also begin colonoscopies between 20 to 25 or 2 to 5 years younger than the earliest diagnosis in the family, and they should do those every 1 to 2 years depending on findings. So why are patients with Lynch syndrome recommended to undergo more frequent colonoscopies compared to patients at general risk for colon cancer? This is in order to maximize the likelihood of detecting precancerous adenomas or early-stage cancers. The frequency has to do with how quickly an adenoma or polyp progresses to an invasive cancer. In patients with Lynch syndrome, on average, a benign polyp can become invasive cancer in 1 to 3 years. Waiting longer in between colonoscopies for these individuals would lead to a higher number of patients being diagnosed with later-stage colorectal cancer instead of removal of benign polyps or detecting early-stage disease. This is compared to the progression in the general population. It takes approximately 5 to 10 years for a polyp to turn into invasive cancer, which is why screening recommendations for colonoscopies in the general population start with every 10 years if no polyps were identified. In addition to colon, uterine, and ovarian cancer screening recommendations, patients with Lynch syndrome should also consider increased screening for other cancer types. However, these patients should be referred to a GI specialist for management, so we will not review the recommendations for each cancer types in detail. Certain risk-reducing agents are available to patients with Lynch syndrome in order to decrease their risk of cancer. First, aspirin has been shown to reduce colorectal cancer risk. However, currently there is not enough data to make standard aspirin use an official recommendation, but this can be individualized for each patient. Second, oral contraceptive pills have been shown to reduce endometrial and ovarian cancer risk by up to 50%. Lastly, progesterone-only IUDs have been shown to reduce endometrial cancer risk by up to 50%. However, progesterone-only IUDs are not associated with risk reduction for ovarian cancer. Therefore, for patients with Lynch syndrome, a comparable oral contraceptive can provide risk reduction for both uterine and ovarian cancer. Thank you for your time and attention today. For more information about Empower, Natera's hereditary cancer screening panel, please visit our website at natera.com or call 844-778-4700.